Welcome to the Mayo Clinic Ophthalmology Podcast, brought to you by Mayo Clinic. I'm your host, Dr. Andrea Tooley.
And I'm Dr. Eric Bothan. We're here to bring you the latest and greatest in ophthalmology, medicine, and more. In today's episode, we have the opportunity to do Journal Club again on a retina paper or two. We invite Dr. Matt Starr, a vitreoretinal surgeon here at the Mayo Clinic, to talk about two articles, the first of which is Outcomes of Intentionally Suspending Treatment in Eyes with Advanced Neovascular Age-Related Macular Degeneration. This article was recently published in the AJO, and we will discuss it shortly. The other one, which will follow, is called Retinal, Arterial, and Vein Occlusion Risks After Coronavirus Disease 2019 or Coronavirus Disease 2019 Vaccination. A fascinating article talking about whether there's a relationship between retinal disease and coronavirus.
Dr. Matthew Starr is a vitreoretinal surgeon here at Mayo Clinic. Dr. Starr completed his residency at Mayo and vitreoretinal surgery fellowship at Wills Eye Hospital. During his fellowship, Dr. Starr was awarded the Ronald G. Michaels Fellowship Foundation Award. In 2021, he was the Macula Society Evangelos Gradudas Award and lecture winner. His clinical interests include clinical management of vitreoretinal diseases such as diabetic retinopathy, retinal vascular disease, and age-related macular degeneration, as well as the surgical treatment of complex vitreoretinal disorders. Welcome, Dr. Starr.
Thanks so much for having me. Happy to be back.
That's a mouthful. You have so many awards.
It's been a while, though. It's a few years old now.
We're so proud of you.
Thanks.
Well, it's a delight to do Journal Club again, and we certainly like to unpack articles for our readers. The first of which we're going to introduce, and I am happy to say I want to start out with just some background information because as a pediatric ophthalmologist, I like to tap the brain of a retina specialist before we get into this complex article. But the article we'll be talking about, as you know, is Outcomes of Intentionally Suspending Treatment in Eyes with Advanced Neovascular Age-Related Macular Degeneration. And this was published in the AJO by a group led by Dr. Catherine Awe, and in 2023, recently published. And this article talks about, is it okay to stop injecting? But before we get to this article, we get you on the mic to share with us about injection practice as a whole and where we stand today. I appreciate the work it is to screen of patients with a variety of conditions and start their injection practices. Share with us kind of what your perception is of the landscape of injection practices and retina practices, or places like Mayo that might do it a little differently, and how, when patients need injections, how they're enrolled in protocols to get treatment.
Yeah, I can remember when I was a medical student interested in ophthalmology, and there was an oculoplastic surgeon said, retina is the wild, wild west. You never know, and it's still the wild, wild west. Things are always evolving. There's no new frontier, and that's, ever more present now with injections. And so we're always getting new drugs, new types of medications, and it's a little bit tricky for patients and other physicians who are not always involved to kind of keep up with all of it. Right now Mayo it's about 5 or 6 types of anti-VEGF injections, the newest one being something called Vabysmo, or faricimab, and that's the latest and greatest perhaps. But then now you've got something called Eylea HD, which is a more concentrated dose of Eylea, or aflibercept. And then coming down the pipeline, there's even more. And then there's different types of intravitreal injections, not only looking at anti-VEGF, but different other modalities and target pathways for patients with diabetic retinopathy, macular degeneration, retinal vein occlusions, all sorts of new stuff from an injection standpoint. And then, not only injections, you're looking at different implants. Recently, there was an implant place that is now kind of off and then coming back onto the market, looking at something that works for 6, 9, 12 months, and you refill it in the office, but it's something you implant into the eye. And then you look at things like gene therapy, which we're doing clinical trials here at Mayo Clinic for patients with macular degeneration, where we deliver gene therapy subretinally, and then hopefully those patients either stop or have a significant 90-95% reduction in the number of injections they need, and that's the latest and greatest in this ever evolving field for intravitreal anti-VEGF or intravitreal injections. Mayo Clinic has a unique injection practice. When we see a patient either sent to us or in our clinic, we typically will send them to what we have an injection clinic. Unique to Mayo is we don't typically do injections, right there in the office. A lot of retina private practices, a lot of other institutions will do them kind of in the chair. We have evolved kind of this injection clinic where we send patients up to a hospital-based setting. They have a whole kind of algorithm and protocol for how they do injections and how they prep the patients, and that's really worked well for us. And we've had a significant reduction in, we never really had a high rate of infections, things like that. But we found that the rate of infections is quite low, and when you compare that to the national average, is quite lower. And for us, it streamlines clinic. We're not bogged down doing injections. We're having an injecting physician who's a retina specialist doing them essentially every day for 3 or 4 hours, and it seems to work really well for us. Unique to that again too is we don't get an image every time. That's something different too. A lot of physicians will utilize OCT when they're performing an injection every 4, 5, 6 weeks or whatever, where we have a protocol where they come in, they get their vision checked, and then if they meet these criteria, they can go up to the injection clinic and get the injection and go home. Dr. Brittany Scruggs here is working on kind of analyzing some of the safety features of that, and we found patients are satisfied. They're really happy with this. They're not being bogged down getting images, waiting for images, talking to the doctor. They're coming in, getting the pictures, getting the injection, and going home. And that again works really well for us in our practice, given the volume of patients that are coming through our doors. And I think it works really well for our what we have here at Mayo.
Yeah, it's so interesting, Matt, to hear about this. And I kind of grew up with this structure being a resident at Mayo, just like you. And so I've seen injection clinic. It's super safe, extremely streamlined, like you said, great patient outcomes, and patients love it. It's a very unique practice to Mayo. Before I want to go into more of those protocols, like how you decide to do treat and extend versus for us, say, an injection every 4 weeks times 3, and then come back and we'll evaluate you, or how you make those decisions. Can you take us through the landscape of the meds, how you select the med? I was just in DC recently, and we were talking about step therapy, which is a huge struggle for retina specialists. You have to fail Avastin first or whatever. So how do you decide what med? And then let me just also add a caveat just for the podcast in general. We'll probably have some brand names and be talking about some products and things here, and it's purely an educational purpose, and we're just using it to kind of discuss those things. So just a little disclaimer, but take us through the drugs.
Yeah, it's easier to say Vabysmo or Avastin than bevacizumab.
Yes.
Or faricimab.
Yeah, don't make me say bevacizumab.
No. So yeah, it is an unfortunate. You can get way off topic, and insurance companies unfortunately dictate a lot of how we practice. And when choosing medications, a lot of times I'm up to what the insurance will cover. A lot of times you can have pre-approval processes, but then that may delay care. So if you see a patient and you want to give them, let's say, Eylea or Vabysmo, insurance may need a couple days to run that, where I can just say, okay, get Avastin, you'll get it today, and you'll go home. And I don't know if one is safer than the other, but recently there was the DRCO protocol looking at diabetic patients when they did implement step therapy. And when you really dissect that kind of paper, they found that step therapy was safe. From a vision standpoint, a number of patients, I believe it was 50 to 60%, were able to stay with Avastin and didn't meet switching criteria, although their switching criteria were pretty stringent. And so that kind of played into insurance companies' hands, perhaps for diabetes, that you can potentially start with Avastin and still safely transition to Eylea later on without compromising vision. However, there are other protocols that have said when you start with Eylea for certain vision cutoffs, you have better vision overall than if you started with Avastin. For me, I typically, if I see a patient, I'll assess their baseline vision, their baseline OCT pictures, whether there's fluid, scars, things like that, and decide. For the most part, I will start with Avastin or bevacizumab, and then after a few injections, depending on what the disease is, if they've responded really well, keep going and then extend them. We have a kind of a modified extension protocol where we start in kind of 2-week increments, but we do them in series, so it's not we're seeing them back every time. What the true treat and extend is you see back 6, 8, 10, 12, and then you keep going from there. I don't think a lot of physicians are continuing monthly dosing. When you look back at the earlier trials, monthly dosing was maybe the best, but it's a big burden on the patients.
Mm-hmm.
To come in every single month. These patients are elderly, they're sick, they need help from family members to get to these appointments. So we're trying to balance all of that out, plus the cost on the healthcare system. It's an ever-evolving kind of push and shove. Kind of what's best for the overall picture for healthcare.
So, as we're going to get into an article in a few minutes, but share with us what the typical schedule. You say monthly is becoming less commonly utilized, but what's the typical schedule, first of all? Is there ever end in sight? And then when do you try, if you think end is in sight, stopping, and how do you do that? So 3 questions. One is, what's the average frequency? When might consider stopping, and how would you stop? And that'll lead us into our article.
Yeah, I think monthly is really uncommon. I do have, I know them all by heart almost, the patients that need a shot every 4 weeks, and it's so uncommon that I know them really well because they're coming in so frequently. But in the era of the newer anti-VEGF agents, it's really uncommon for us to have to give a patient a shot, and they really need it. Some patients, there's even reports of you needing shots every 2 weeks. And, that's where it's really tricky. For most of mine, we start, by the clinical protocols where we load them, loading dose for 3 to 4 months every month, and then if they have a response, most physicians will do 2-week interval increments, and then make sure they're doing okay, check them back, and then gradually extend them out over many, many months. When I first meet a patient, I tell them you're going to need shots for a long time, indefinitely, at least several years, if you can buy into that. Just so they upfront know this is not, a one and done. I tell patients this is like diabetes or hypertension. We're going to manage it. We're not going to cure it. And just most of the time they kind of understand those kind of systemic correlations, and they kind of buy into, okay, I've got a disease. I need treatment. I say Band-Aids. You need to reapply the Band-Aids every month. And then hopefully my goal is to expand that out so you don't need them for maybe 2 or 3 times or every 2 or 3 months. The most I usually extend out to is 13, 14 weeks. With the newer agents like Vabysmo or faricimab, they showed a lot of patients were able to get out to 16 weeks between shots if they met certain criteria. For other diseases like diabetes or diabetic retinopathy, vein occlusions, when you can give a steroid or steroids are beneficial, those patients may go many months if they're getting agents that last 3 months to some are now 3 years. They still need treatment every now and then. They don't go through years without treatment, but there is a lot of things that are increasing durability.
So no real end in sight for most. Just the frequency changes.
Frequency change. I think
Okay.
I tell patients if you can just buy in that frequency is our target, and then if you can get there, I usually give you a chance to stop. There's an older paper, not this one, that showed about 50% of patients, if you can get to 3 months between shots, can stop them and not have to return to injections. So 50% return to injections with an initial drop in vision. However, that recovered to their vision after stopping, and so no depreciable, at least, vision loss in that study.
That kind of brings us to our paper. Let's segue to this paper, Outcomes of Intentionally Suspending Treatment in Eyes with Advanced Neovascular AMD. And so this was a really nice, super well done paper in AJO to determine the outcomes of intentionally stopping anti-VEGF injections in these eyes with advanced neovascular AMD. It was a retrospective cohort study. They had 93 patients with AMD and poor vision, 2,400, in which the treatment was stopped by the treating physician. And then they looked at visual acuity, OCT. They looked at a bunch of different outcomes to kind of see what happened during the next 24 months after stopping treatment. Can you kind of take us through what was the point of this study? Like, why do we want to know this? And then what they found?
Yeah, so I think this is a huge question. Is a lot of patients come in saying they don't see anything anyways. Why treat it? And I tell all patients, we can get some subjective improvement likely. And usually with a fresh AMD, they're going to see definitely some subjective improvement. I've yet to have one where they don't notice really anything. And there's some really bad ones. This paper was looking really at those who've been treated for at least a year. And then they're still, they say 2,400, but the majority were count fingers. They're not, these patients
it's
are
worse than 2,400, is that right?
Yeah,
yeah.
2,400 or worse, I think. But they kind of comment that most of them are hand motion count fingers vision, which is, that's really, poor vision.
Mm-hmm.
And so at that point, what do you do? And so I think, they found that in the population where they're fairly stable, their vision's still really poor, do we just intentionally stop? And they found really no change in vision when you look at long-term data. They had fewer patients follow up 1 year, 2 years out. Initially there was some mild vision decline, but you're splitting hairs at count fingers vision, and so it gets a little tricky there. And then they really didn't find any difference in fibrovascular lesion, discoform scars, things like that. They actually had reduction in intraretinal fluid, which was kind of interesting. That seems kind of paradoxical. Intraretinal fluid's kind of like our hallmark for activity. They kind of postulate, this is perhaps just end-stage natural history progression of these lesions where they kind of die out or burn out. Mm-hmm. And so I think it does kind of validate. They mention a lot of retina physicians do this. There's just no data really to kind of support that. Mm-hmm. A lot of patients are either getting injections or getting them frequently, and they just don't see really well. So, why do we keep doing it? Again, it goes back to a lot of my patients are elderly. They have to have family bring them in for these shots. Mm-hmm. What are they doing? They also really nicely point out that 90%, that's their worst seeing eye. Okay, so they have a better eye to rely on. And so that, I think, plays a big role into it. A lot of times if it is a monocular patient, we're hesitant really to kind of really pull back on anything.
That all makes sense.
Yeah, I thought it was interesting that, even many of these, it said 60% or so still had subretinal fluid, 30% still had intraretinal fluid, hemorrhage was present in 30%. So these were eyes that were still wet and juicy, and yet because the vision horse was already out of the barn, they sort of thought, let's just back off. And as you articulated, they, for the readers that are listeners, measured foveal thickness and lesion diameter and greatest lesion thickness, wherever it might be. And only 7% did they go back on some treatment for some reason, even though the bulk of the data would show that, for the most part, lesions were stable stopping.
Yeah.
It was encouraging that so few must have progressed enough that they thought, and this is retrospectively, there was no, protocol for when to restart, but for whatever reason they thought, at least in just a handful, it'd be reasonable to restart. So yeah, it's just, certainly eyes that were still meeting criteria to keep going, but yet because the vision was so poor, they thought it was reasonable to stop. You did comment on the loss of follow-up. In any retrospective study, there's always that risk that some of the people you really want to know how they're doing are not coming back anymore. And certainly in a retina practice with poor vision, it's possible that they saw somebody else because they weren't getting better in that eye. But I mean, I think at 2 years, or it dropped to 63% at 18 months, and then 56% at 2 years. So they'd lost they said the majority, but they'd lost almost half the patients in 2 years. So that was just a qualifier that could be there too.
Yeah, and any retrospective study is going to have some sort of limitation. And a lot of these patients, again, they follow up elsewhere. They just don't want to come back. A lot of times when we make these decisions with our patients, we say, you can follow up locally, or you can follow up with your primary care ophthalmologist or your optometrist, and you'll send us records, things like that. And that works out. They're going to see other doctors, other physicians. You're going to have other problems like glaucoma, things like that. Who need care, and so they sometimes will kind of cut the retina doc out and go see the other ones. We see that pretty frequently.
One thing I've noticed with AMD is that even if it's end stage and severe, maybe we worry about them getting a bad hemorrhage or a bunch of heme, and then I guess that could progress to bad glaucoma or something. But as an oculoplastic surgeon, I'm always thinking about, then the eye is going to become preticical or ticical or a blind, painful eye. I never see blind painful eyes from AMD. It's just not a thing. I don't think I've ever done an nuke or an vis for a blind painful eye that AMD was the reason.
Yeah.
So that's not something we have to worry about here.
Yeah, I think for AMD specifically, I tell patients you're never going to be blind from this. You may be legally blind and you may not see anything, but you'll always have your peripheral vision unless you've got some sort of, really atypical, bleeding problem or it's polypoidal or something, or there's different things. But tried and true, like age-related macular degeneration, you're going to always have your peripheral vision, at least some of it. And so I think for those patients, when they're saying, hey, I don't really care if my blind spot's a little bit bigger, I think they decide that it's just not worth it for them to continue treatment.
I think the burden of injections is huge and really hard for us to understand, but it must be horrendous for patients.
You made a comment that this is the worst seeing eye. I don't hang out in retina clinics as much as I did as a resident, but it was quite striking when back in the day all you had was PDT when I trained or whatever it might be, but in lasering these. In a practice right now for comprehensive ophthalmologists that don't see retina patients all the time, they usually see one of these and say, help, and they punt it. Yeah. How rare is it to be less than 2,400 in both eyes these days with current treatments like we have?
Yeah. It's really uncommon. Again, it's less than a handful in my practice. A lot of times these patients come in when their good eye goes, and they realize it because they just haven't seen out of one eye, and then they finally kind of come into the doctor when their good eye kind of starts to lose vision, because even then most patients, as soon as they start losing vision in one eye, will be treated. So the fact that the number of patients with one really bad eye, less than 2,400, that's even more rare. But those patients will still come in once they really start to lose vision in a good eye. And with the newer agents, we've shown that patients can get injections 10, 15, now we're seeing up to 20 years, and they maintain good vision as long as they maintain treatment. And then there's geographic atrophy and dry macular degeneration, which can
it's still there.
Yeah, but these injections work really well, and a lot of patients are 20/20, 20/40, just getting their injection.
That's wild.
Well, on this topic of injecting vascular abnormalities in the back of the eye. I mean, this was a nice highlight of just the injection practice, but also ARMD. Let's switch gears to another vascular abnormalities in the back of the eye, retinal vein occlusion and arterial occlusions related to COVID. Andrew, you want to introduce this article for us to talk about?
Yes, so this is retinal artery and vein occlusion risks after coronavirus disease 2019 or coronavirus disease 2019 vaccination. And this is a huge study. It came out of ophthalmology last year, 2023. It was a nationwide population-based cohort study out of Korea and looked at the incidence of new RAO, retinal arterial occlusion, or RVO, retinal vein occlusion, after the diagnosis of COVID-19 or after vaccination against COVID-19, and compared it against the entire population. They had over 8 million people in this group, and they separated them into three groups. One was the control group, no COVID, no vaccination. The second group was the COVID-19 group, so had a COVID infection. And some had vaccination and some hadn't, so that was a little bit of a variable group. And then the third group was the vaccinated group, the COVID-19 vax group. And also represented a variety of different vaccine types. Moderna, Pfizer, lots were included in that type, but huge groups, 8 million patients, and then they followed the incidence and looked at hazard ratios and overall incidence between the three groups, did a big multivariate analysis to compare with other risk factors, and looked at the cumulative incidence and then the risk of incidence from index day to 60 days after. And a very interesting study. I think the take-home point is that there were no significant increased risks in the vaccinated group or the infected group. That's kind of the big generalization, but if you look at the data a little closer, there were quite a few differences. So we're going to dive into this, and I think the significance, and we can talk more about this too with Matt, is that I still have patients ask me all the time if whatever their pathology is from COVID or from their vaccine. Things that are super unrelated. Do they have a new meningioma? Is this from my vaccination? And so I think it's nice to have some data, especially on these arterial and venous occlusions. We know that there's been a lot of talk about COVID having higher incidence with thromboembolic thromboembolic events and pro-inflammatory type of things. And so these data, I think, are really helpful when we talk with our patients. What do you think, Matt?
Yeah, I mean, I think the biggest thing for me is when I counsel patients, I get the same question in the retina clinic. Oh, did COVID do this? Did my vaccine do this? And it was a really hot topic, a year or two ago, and right when everything was going on, and I get it less and less now, but still, I had this week had someone asked, and I think this kind of gives me some guidance to say there really is not a lot of good data to support yes or no that COVID or the COVID vaccine led to your retinal vein occlusion or retinal arterial occlusion, and I think this kind of highlights that there perhaps there really is no association. I think, like you alluded to, there's a few interesting kind of topics or discrepancies in the paper. I think jumping into it, the cohorts weren't really balanced really well. I mean, in 2021, when they made the control cohort, it's really hard to find someone who didn't have COVID or had the COVID vaccine, especially in a country where the government mandated vaccines. And so that's a little bit of a more nuanced or tricky to define cohort. And then when you really looked at it, they did find significant increases in RAOs and RVOs in cohort 3 or the vaccinated cohort. But when you ran kind of the multivariate analysis, the sub-analyses, and really divided it in multivariate and hazard ratios, there really wasn't a difference. They did find that on subgroup analysis, females who got an mRNA vaccine did have higher rates of RAOs. But again, they're not controlling for other things. We didn't get any data on laboratory values. Previous studies have shown after the COVID or COVID vaccine, you get elevations in CRP, ESR, D-dimer. Those things are really big risk factors for thromboembolic events. And so, some of those things were just kind of missing from this. But I think, again, this kind of goes back. It's really hard to say.
I think for people that aren't in academic practices that don't read through statistics commonly or have statistical help around them, it's what your comment over multivariate analysis is important. And just for anyone understanding basic stats here, and learning about basic stats, you can have a study like this with really big numbers that by univariate analysis, just looking at one factor, was being female, or was having COVID, or was having high blood pressure associated with some event. But unfortunately, we know that if COVID was more, tended to be happening more in certain groups, it might not be that the fact that they had COVID but it was their age that was the driver. So even though, if the elderly patients came into the hospitals more commonly and were diagnosed more commonly with COVID than a younger person, when you need that multivariate analysis, instead of looking at the individual bucket, look at how the buckets cross-contaminate or complement or are separated. And when you do that, multivariate analysis is helpful to say, if the statistical significance disappears, when you do that, it means it wasn't a significantly associated risk, at least in the study, if it was well designed. And so that's why you're saying, even though some of these buckets, like the COVID group, looked potentially like there was a trend there, it went away when you multivariate analysis or other statistics were applied. And that was just helpful. I agree with you. It continues to pop up, and no matter what, I think there's been a degradation in our society appreciating science. And so having more science behind data like this to help the emotions and the feeling behind opinions, whether they're seeing something more, is so helpful.
Yeah, I mean, it's nice. I mean, this is the biggest study, on this kind of topic right now. Then they comment on, its case series, and there was a couple of 100 patient papers done before this, but I mean, on a national level, hundreds of thousands, millions of patients, and the events are small, and they're trying to answer a really hard question, and the data gets murky, and then once you kind of finally tease through and do the, like I said, the in-depth or very detailed statistical analyses, there's just nothing there.
Yeah, exactly like you said. The groups were a little bit uneven. I mean, if you look at like 2 million in the control group, so that was no vaccine, no COVID, and their average age was 35, versus group 2 was the COVID group, only 500,000, only 500,000, so quite a bit smaller. Their average age was a little bit older, 41 mean, and then group 3 was the vaccinated group, 5 million, so much bigger, 10 times bigger than group 2, but their average age was also quite a bit higher, 52 as the average, so big age difference there. And then like you said, Matt, if you look at the actual numbers, like the number of events, we'll link this article in the show notes so that you can see some of the figures. But in figure 3, they have a list of cumulative number of events, and they are quite a bit higher in the vaccination group. But again, this group had 5 million people compared to only 2 million in the other and 500,000 in the other. So that you can skew the numbers to make it look however you want. But at the end of the day, the data are what the data are, and it is a tough question to answer.
Yeah, and these are events that are happening. I mean, you don't typically see an RAO or an RVO, a vein occlusion, arterial occlusion, in a 35-year-old, you know?
Sure.
And so you're going to see them in a patient who's, you know, a little bit older, usually in their 50s, 60s, 70s, 80s, who've got systemic, you know, comorbidities. You know, we know that it's associated with hypertension, high blood pressure, you know, all sorts of other things. And, you know, they controlled for a lot of those risk factors in there. And I think, you know, there's been other studies that have looked at younger patients. You know, I think it would have been kind of nice to see not only male-female breakdown, but, you know, age breakdown.
Age-adjusted
because
groups.
You know, some studies have, you know, positioned that having COVID will put you at a higher risk for RAO when you're 25, 30.
Sure.
You know, yeah, so be it if you're 45, 50. You have other things that are affecting your health, and so you may have developed those because of those other risk factors. But if it's actually affecting younger patients who shouldn't be really getting this, or we don't see that often, you know, that's a different kind of question.
Mm-hmm. Very interesting. Yeah. Does this change the way that you counsel patients, or change anything you say to your patients?
I don't know, not a little bit. I mean, it gives you a little bit, but I still tell patients that you can find a study saying yes or no to whatever you want. Yes. I think it's really hard to say COVID or COVID vaccine caused this, and I don't think there's enough data to support yes or no. I think right now this would be a little bit more helpful for me saying, you know, look, it's, if you have, you know, I tell patients, get the vaccine. You know, there's really not a good evidence right now to say it's causing any problems.
Right. Wonderful.
Well, thank you,
Matt,
for joining us and shedding light on these vascular processes and anti-VEGF. And it's always fun to tap your insight and have you here with us on the podcast.
Great journal club. First retina articles I've read in too long. Thank you so much, Dr. Starr.
Oh, no, happy to be here.
You can find all episodes of the Mayo Clinic Ophthalmology Podcast on our website.
Thank you for listening, and we definitely look forward to sharing more